thank you for having me. I am quite fond of the subject for a couple of reasons. And I think it's because of my age, and I think it's because I've been in nursing for so long, that I am now free to talk about having been the victim of bullying and how destructive it was to me, and how I lived with the insecurity that comes from being a victim and the pain. And more importantly, I freed myself from it after about 25 years. And so my mission, now that I'm on the back end of my career and I have more road in the rear view than I do in the windshield, is to really become an advocate and really talk about to anybody who will listen that there are 3.1 million registered nurses in this country. We are the largest single group of providers. We have the most incredible opportunity to use our voice in the most productive ways. If we were to pull together and we were really to say, in nursing, we are not going to allow this behavior any longer, think about how powerful that would be. I would venture to say that every one of us in this room this morning has had or continues to have some level of experience with bullying. Either being a victim, which I hope not, or being a bystander. And I'm sure, because I've been told, and I believe it wholeheartedly, that at York Hospital, bullies are not allowed to work here. So I know no one in this room is going to be identified as a bully. But we're going to talk about a few things. And I have to be honest with you, sometimes we talk about these things and it does resurrect some negative emotion. And if that does, sometimes it resurrects my own experience. But if it does and you need to leave, that please feel free to do that. But if you also need to be what we call rescued, and you're open to be rescued, I'm very happy to stop what I'm doing and provide you with a hug. Because sometimes as victims, that's all we've ever needed, was for someone to come along and say, it's okay, you're still a really good person. And that doesn't happen that often. So we're going to talk about disruptive behavior, because bullying is just one behavior on this continuum. We're going to spend a lot of time on bullying, and then we're going to talk a little bit about the prevention of it, because it can be prevented. I mean, we don't have to accept that as a profession, this is one of our tenets. We just don't have to accept that. We can say that we do not allow bullying here. And if we each do that by our organization, by our schools, by our groups, then we can totally eradicate it. But we're really going to focus on a couple key points. How the organization does it, and I think I see some very profound, very impressive strategies already in the organization. I walked down some hall, because I'm all turned around after being toured this morning, and saw posters hanging with what the expected behaviors or the values are, and they're all very positive. I see on your badges, kindness and loving, or loving kindness. I mean, those are all organizational stakes in the ground defining who you want to be. We're going to talk about the role of nurse leader, and then we're going to talk about the role of the staff nurse. At any time we can stop, you can ask questions, you can challenge me, you can disagree with me, You know, like I said, I'm an old nurse. I got a thick skin. So, you know, I love the professional debate because whenever a colleague engages me, I always walk away learning something new. And I always appreciate that. I put this slide up. The very first time I used this slide was when I did grand rounds at Mass General. And what I was presenting, of course, was bullying, but it was really my thesis from my doctoral work. And I was looking for like a really cool graphic. And so I went to the internet, I went to Google, of course everybody goes to Google, and I Googled nurse bullying, and you know, something like 100 million sites came up in, you know, like less than a nanosecond. And, you know, always in Google, like about 3 lines down is images. And so I thought, all right, well, this is what I need. So I clicked on images, and this was the first image that came up. And I was totally, totally, totally taken by it. And there isn't anybody to reference. There was no reference, so whoever the artist is, I give them credit for this. But what I really give them credit about is how painful a picture this is. And as we think about the symbolism, of course it's, you know, the nurse with the cap, so that thing. But the whole idea that nurses eat their young, and this young nurse calling for help in what looks like a bloodbath, and we don't know who's under this cap or where the person to this cap went. And so, of course, this is very reminiscent for some of us in the room. Remember the article. It was a sort of startling landmark article, Why Nurses Eat Their Young. And so it really represents this phenomena of what we do to each other. And I think what I particularly find, you know, it's like the car accident. You know how like you don't want to look? You want to respect people's dignity, but you can't help but slowing down and looking because you really want to see just how bad it is. There's something that always draws us in, and as disturbing as I find this picture, I'm always drawn into parts of it, and I think that's because of my own experience. And sometimes I think, you know, am I here? I certainly hope I haven't been here, although I will tell you, and I use my own story when I lecture, that even though I lived as a victim, or I lived in victimhood for 25 years, when I taught nursing school and I was accused of being a bully, in retrospect, I can see how easily it can happen without being aware of it. And that's some of the theory behind why bullies still exist, although we're going to talk about a couple of different ones. So if you haven't figured it out, this is really all about me. And so I always dedicate when I lecture on bullying to all of those who are survivors, but more importantly, all of those of you who reached out and helped save me and helped save the victims. Because without us reaching out and saving them, we could lose them forever. And nursing is too fragile to start losing our most precious resource, which is new nurses. They are our most precious resource. So let's begin a little bit. And a lot of this you know. I mean, I'm not here, you know, preaching from the mount with you know, 10 commandments on 2 stone tablets. I mean, you know this stuff. And what we know about disruptive behavior as a concept is that it interferes negatively with normal operations. And if that's the only thing that you walk out of here hearing in your head for the rest of the day, the rest of the weekend, the rest of the month, is disruptive behaviors negatively impact normal operations. And when we think about it in that context, when we think about the context of normal operations, we can apply that to just about any division, department, service, or area. So when people are disruptive in nutrition, think about what happens to trays. Think about what happens to the cafeteria. When things are disruptive in the billing office, think about what happens with bills getting out or payments not being entered. What happens to the cash flow? When things are disruptive in pharmacy, buildings and grounds, think about the impact. But now think about when disruptive behaviors negatively impact nursing operations or physical therapy operations or occupational or respiratory or any other provider group. The disruption is on patients. And that's the simple fact that we should never forget. Disruptive behavior is an interruption in operations based on what my role is. And if my role is as a provider or a clinician, it's on patient care. Any disruption in patient care automatically will take you to patient safety or lack thereof. Disruptive behaviors, they present themselves as overt or covert. Overt are pretty obvious, and I hope that in 2016, overt behaviors don't exist anymore. I hope that surgeons don't throw anything at nurses or others in the OR. I hope that people don't slam charts at the desk. I hope people are not having loud exchanges in public spaces. I hope people are not being threatened with violence. But the covert, I bet you still happens. And I bet you it's happening right here at York Hospital. Covert behaviors are very insidious, and they are the most harmful. Because covert behaviors go to psychological safety, versus the overt go to your physical safety. You know, if someone starts throwing scalpels at you, you better duck. Versus if someone starts spreading gossip about you, how do you duck? How do you get away from that? We're also going to talk about, and I might as well just throw it out there now rather than, lead up to the suspense. There's also some literature that exists around bullying in particular that really talks about overt behaviors and covert behaviors having a gender perspective to it. And that when men are engaging in disruptive behaviors, they're much more likely to be overt versus women who are very much covert. And we're going to talk about relational aggression, one of the articles that I sent. But I like this idea, is that it exists on a continuum. And as we know as providers, continuums are not fixed places. Continuums are fluid. Continuums have movement. I can go from one end to the other. I can slide up and down. I think of continuums for those of us who remember slide rules. You remember that little clear plastic thing that went up and down? That's how I see that. I can be in any variation of disruptive behavior. And that's what makes it very hard for us to have absolutes. Thou shalt not, because it's so fluid. So at the very low end of disruptive behavior is, when I first started studying this stuff, it was very, very sparse in the literature, this idea of incivility. Very, very sparse. The first time we actually heard about it through literature was around 2009, maybe 2008. And it was being described at that time, and I think it has expanded. So now it's a major phenomena in our society. This idea of lacking social behaviors, acceptable social behaviors. And there's some who believe that portable technology is driving an increase in incivility. There are others who also believe that incivility has grown and acts as a stepping stone to more aggressive behaviors because there can be an anonymity to who I am and the stuff that I sling. So I can say things on Facebook, I can put things on a blog, I can be out in the world, if you will, behind this protection, and I can say whatever I want. Email is a huge contributor of this. We're supposed to believe that email doesn't have a tone, and yet we all know that email that comes across that you say, ooh, I wish she was standing here right now. I'd give her a piece of my mind. Versus, oops, I better get out of here before someone finds me. Versus, aren't they sweet? Even though the words are exactly the same, there is some tone that comes through. So incivility is really about how do we interact and engage with each other in just very acceptable ways. Please, thank you, may I? One of the examples that I am fascinated by, because it probably has been going on even before we had the term, and this has happened to all of you, where you're coming in the door, someone's coming out, and just being the polite person that you are, you hold the door and let them go, and they don't say thank you. That's incivility. So where I come, I come from Boston, and so we ride the subway or transit, the public transit, and we have those seats by the doors designated for the elderly, persons with disability, and now for pregnant moms. And, it means get up and give your seat up. And it's very often women who will get up, but men won't. And I'm thinking, that better not be me, because my cold dead mother will come out of the grave and just smack me upside the head if I didn't get up or hold the door or say, yes ma'am, no ma'am, please, thank you. But that's incivility. But we see incivility come about in the workplace, and it comes through these ideas that I am in an environment that is contributing to my sense of not feeling taken care of, not feeling valued, not feeling like I matter, this sense that no one's paying attention to me. I remember I was a brand new graduate, and for those of you who remember, in those days we could practice as nurses without a license. We were GNs because, we didn't take our state boards. They only gave them twice a month. And I can remember I worked on a 41-bed neurosurgical unit, and it was separated into 3 wings, north, south, east. East had the most beds because the south wing had all the ventilators, and the north wing, although they had the 4-bed rooms and all that, that was the nurse who was going to be in charge. And there were only 3 of us on the night shift. And I can remember, I must have only been out of school a couple of weeks, and I can remember in the middle of the night standing in the corridor, holding a bunch of those, remember those little souffle cups we used to put pills in? And we used to write in pen, and it was right on the bottom. We wouldn't dare do that now. But we'd write on the bottom 16B and 16A and all that sort of stuff, and hope that you didn't drop those cups, because then you would have never figured out where what went back and what. And just standing there thinking, Holy Mary, Mother of God, does anybody realize they have left me alone in the middle of the night with sick people? What the hell were they thinking about? What sense does that make to put brand new graduates on the night shift with 14 patients? But that's the kind of stress, the environmental stress, that can contribute in nursing to these growing levels of incivility. And the literature does talk about that women are always more exposed to incivility. And personally, I think that's just commentary on where we are as a society and all the work left that we have to do in having, and I'm not going to get political, even though, you know, I'm in Maine, so we're pretty close to Vermont, about, you know, equal rights for all citizens. That's the last word I'm saying about Bernie or Hillary. So the next stop on the continuum is bullying. And we know it's a severe workplace issue. This, for me, is really where it's all about. It causes severe emotional damage. More importantly, it has negative effects on patient care. We know it has tremendous damage on the organization, and it has a lot of other harmful peripheral kind of effects. So let's dissect this a little bit. The problem with bullying, well, there are many problems with bullying, but the first problem with bullying is that there is no definition of it. There's no one single definition of it. If I say the patient is febrile, you know what that means. If I say the patient is neutropenic, you know what that means. If I say the roast beef is burnt, you know what that means. You can create a mental image. You can define it. But when I say she's a bully, there's no definition for that. We take a personal and a perspective to that. And part of the danger, and this is it, I don't want you all go off running off now to be bully police, although you should be. But, you know, before you start arresting anybody, be real careful with the label. Because there's variations to this where the person may be engaging in violence, psychological violence, but they're not bullies. So when we think about what bullying is, there's a few things that you have to always be able to identify. It's like doing nursing diagnosis, as much as I hate those, by the way. It's nursing diagnosis. What are the characteristics? What are the defining characteristics? And there are probably many of them associated, or we can find in the literature. But the three that I always look for when I'm consulted about is bullying going on here is the behavior targeted towards an individual, because it's always towards an individual. Is it intentional? And does it cause harm? Is it targeted, intentional, harmful behavior? The other element that you have to be sure about, is it repetitive? Is it predictable? Could you, if you could get through the IRB, could you establish a control group and an intervention group? Could you actually set up a situation in which the bullying behaviors exhibit themselves and we could get them on camera, or we could watch them behind a two-way mirror? Repetitive, predictable, targeted, and meant to harm. Harm. And the harm is always in this emotional sphere. Harm is always around or designed to be in the public humiliation. So this is where I get to tell you my story. I applied to nursing school in high school, and you know, it wasn't cool and it wasn't like groovy. You know, it was the early 70s for a man to want to be a nurse, but you know, somehow or another, I just always wanted to be a nurse. And so I applied to something like 20-something programs. And quite honestly, my grades were pretty awful. And schools weren't interested in me, first of all although only one school actually ever said to me, we've rejected your application because you're a man, and we have a policy not to accept men into our program. And when you really think about a lot of programs in those days, they didn't accept men, and that was their policy, although it probably wasn't written on paper. But a lot of these programs used this idea of, well, your grades really stink. And they did. Out of a class of 200, I think I was like 197. So my grades were really poor. But my grades were a reflection of not having a positive experience in high school. And this idea that I needed to escape. So anyway, that's a different part of the story. So I did get accepted to this one program, and it was a baccalaureate program, surprisingly enough, in the early 70s. And I thought, well, that isn't what I want to do. Real nurses go to diploma school. I want to go live in a dorm. I want to wear one of those funny white uniforms. I want to do all this kind of like real stuff. But, I thought, this is the only place that's accepted me. I better go because, I graduate Sunday. I better have something to do on Monday. So I went, and after about a year, I was called down to the chair or the head, whoever the head of the program was at the time. And of course, being who I am, I was going down there expecting that I was going to get the keys to a brand new Mustang, and I was doing so fabulous and I was so wonderful that they were just going to graduate me right then and there. I was sure that I was going to get some sort of commendation. And what I got was an invitation to withdraw. Again, because my grades were so bad, and it was the age of disco, and I actually had the brass, no brains, but I had the brass to say to her, well, the problem is you start too early. If you started around noon, I could make it. No, seriously. And so with that, she withdrew her invitation, and she just tossed me out. So now we fast forward several years, and it was actually Good Friday, as a matter of fact, as it is today. It was April, and I had what I think was a vision. I didn't see anything, Virgin Mary didn't appear on a sliced toast or any of this kind of stuff, but my consciousness was filled with, all right, you've been hanging around doing nothing long enough. It's time to go do something. And so I went to the phone, and in those days, rotary phone, and I called directory information, and I asked for, the nursing school at Mass General. And the director of the program answered. And it said, I want to come to school. And there was silence. And it said, well, applications stop, blah, blah, blah. And I said, no, you don't understand. I want to come now. And he was like, yeah, that's not going to happen. But there was something in our discussion. He invited me in on the Monday. I went in, and I was very clear with him about what a bad student I had been and some of the reasons why I thought I had been a bad student. And so there must have been something. He challenged me to take a math course, and he set a grade of 95. And if I could get a grade of 95, this is like, sending Dorothy off to get the broomstick of the Wicked Witch. Yeah. You never think she's going to come back with it, right? Well, he sent me off to a math course thinking he's never going to come back with a grade of 95. But I did. I came back, I think it was like 97. And so I started school. And I walked into school, Mass General, and the first person I met identified herself as my instructor, and proceeded to tell me that she comes from an era where men would never have been accepted into school. Nice to meet you, too. And so we then go upstairs to the clinical unit, and she gave me, several patients, but always would stop and say things like, Now you'll remember when you get in there, you act professional. Okay. Another day, she announced at the nurse's station, after I had asked her a question about something that I had just read in the chart, that it would be easier to train a monkey than to teach me to be a nurse. And then another day, a patient was sitting, you know those funny old Jerry chairs we used to have with the trays? Remember those? A patient was in one of those and knocked that little box of Kleenex on the floor, and I went by thinking I was going to be a good doobie, and I picked up the tissues, and she came along and she grabbed me by the ear and said, "Don't you know the dirtiest place in a hospital is the floor? Anything that falls on the floor, you have to throw it away." Well, what do I know? I've been in school like 4 days. So, short time later, she assigns me to an elderly gentleman with dementia. So I thought, well, how bad could this be? And, I go into the room, and I do the whole thing, "Hello, my name is, I'm here too," and, he's got dementia. And says to me, she says to me, "I want him bathed, dressed, and up before breakfast comes." Now, breakfast comes, in the hospital, breakfast comes early. And, I'm a student. The bed bath takes, 4 hours to do? It took me 2 hours just to try to figure out how to get his blood pressure. So, and I had to get the pail of water. I had to make that mitt. Do you remember the mitt? Yeah, we had to put the bath blanket on, pull the sheet from underneath. He couldn't hold it, and I'm doing doing all this really weird stuff. And of course, by now the water's cold. And you wash the eye from the inside out, and he pees. And so I know I have to stop. And so I have to stop. I have to take care of that, but now I got to start all over again. And breakfast comes. And so I get fresh water, fresh towels, fresh bath blanket. I do all of this. I go to touch him again. He pees again. And so now I have to stop. I have to change the sheets. I have to change the pad. Whatever I had to do. And the breakfast is still sitting there. And there was powdery, fluorescent yellow eggs. Remember those? Why do we ever serve stuff like that to patients? When she comes around the corner and announces to everyone, "I knew you wouldn't be able to take on this assignment. All you had to do was wash him and get him out of bed, and you can't even do that." And so now I'm trying to explain to him, oh, by the way, it's August, because we started school in August. No air conditioning, and I'm in that starched white uniform up to here, sweating. You know what off, in that horrible, horrible starched uniform. And I'm trying to explain, and she just simply said, "I don't want to hear it. You've ruined his breakfast, you've ruined his day, you've ruined my morning, blah, 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 blah." And out of her pocket, she hands me this device. It said, "Put this on him." And I look at it, and it says something about being a condom catheter. And now, I know the word condom. I did live through the 70s. I knew the word catheter, but I didn't know how the two words went together. Seriously. And so I took it out of the package, and I'm looking for directions on the package. I used to make macaroni and cheese, so you always got to look for the package instructions. This thing had no instructions. And when I opened it up, I could not figure out this thing that was all folded up or all rolled up in this other sticky thing. And so I thought, well, how hard could this be? They put a man on the moon. I could certainly figure this out. And as I'm trying to put it on him, remember, he's demented. He's yelling, he's screaming, he's kicking. She comes around the corner, pulls back the curtain, and in the loudest voice ever, "Step away from that patient and stop abusing him." And in that instant, I knew my career was over. In that minute, I knew that she had set me up. And so I had to go before a faculty board, one of those like tribunal kind of things, and explained my situation. And of course, she had all this documentation, all this wonderful evidence. I picked things up off the floor. I didn't know how to do this, all these kinds of things. And so after about several hours, or what seemed like several hours, it was probably 10 minutes, again, the director of the school, Mr. Nichols, came out and said, we're going to put you in a special 2-day clinical with another person. And based upon her review, you will either stay in school on probation or you will have to leave. And so I went off for 2 days and got through school. And it was somewhere in that early process where I was called back and told my fate it was okay, I was going to stay. This was probably a misunderstanding. But perhaps it's better for both of you if you not ever show up in her clinical again. Like, not a problem, pal. Yeah. Last clinical, last week, we're in pediatrics. I get assigned 2 13-year-olds with Harrington rods on striker frames. Well, some of you don't remember what striker frames are. But you remember how horrible they were? The straps, the pin, pull them over, the glasses, they'd throw up, they'd get dizzy, put the straps, and so like 13-year-olds, all I was doing like all day long was flipping these 2. My instructor calls out sick. Who shows up? Exactly. And I thought, this is it. Like, I'm destined never to be a nurse. But I got through it. I graduated top of the class, and I was presented with an award for outstanding care by a student. So, fast forward 25 years later, I am now the director of the Norman Knight Nursing Center. I have served 8 years as the deputy director for the Massachusetts Board of Registration in Nursing. I have taught nursing school. I have done all of these things. And I'm assigned to a committee to write a book celebrating 200 years of nursing history at Mass General as we prepared for our bicentennial. I was like, yeah, this is cool. I'll be happy to do that. And I walk into the conference room, and who's sitting there? Her. And I have to tell you, 25 years later, she reduced me again to where I was unable to speak, where I broke out into a cold sweat, where I thought I needed Depends because I don't know what I'm going to do because I can't even get out of the room. I'm paralyzed. And I thought, I'm in my 50s. Like, enough is enough. So that's just my story. And when they do the movie version of it, I'm hoping that George Clooney will play me, because there is a resemblance, don't you think? So when we look at the effects to the victim very much experiences these psychological damaging effects. And we know now, that when the psyche is damaged, it also manifests itself in very physical symptoms. So nurses who are victimized will talk about headaches, will talk about palpitations. They will talk about being sleepless the night before work. They will talk about GI disturbances. They will talk about and will then exhibit a disproportionate amount of things like upper respiratory infections. So one has to now wonder what we know about things like free radicals and all of these other kinds of things, as well as we know from studies What are the hormonal changes within that whole fight or flight reflex that negatively affect us? The bystander is a very interesting group. So in some of the literature, this group is called bystander. This group is also called the fan club. But the term that I like least of all, because I like it least of all because it's so representative, is called the court. Because in the new literature coming out, and it's not that new, it came out like in probably 2010, 2011, this idea of the queen bee, this idea of the mean girl, that the queen bee, if you think about queen bees in a hive, they're surrounded by worker bees. But whenever you think about a queen, you think about the queen's court. Think about high school. What do you have? Homecoming queen and the court. And the court is designed, particularly in bullying, the court is designed to encase the queen and protect her. But they protect her out of fear. And they protect her out of an anxiety that if she turns on me, I am out. I am excluded. I am now going to have to face whatever it is as an outsider. We see these kinds of behaviors in junior high school and high school lunchrooms. There's always that table. There's somebody who runs that table. And everybody wants to sit at that table. It's the cool table. Yeah, it's the happening table. The popular kids. It's whoever it is. And somehow or another, people get in that table. And everything's fabulous. And sometimes you get into that table and what you do is you turn your back on those other people who really like you. And they like you for who you are. But you're in, and that's really cool. It's cool to be in. I've been in. It's much better than being out. Being in is great. The damaging part is when the queen decides you're out. And what's worse than that is you don't know why you're out. And you are out in the most public way. You're usually set up to do something silly like it's pajama day, let's all come to school in our pajamas. And you walk into the cafeteria and, you're Dr. Denton's, and they're all like in designer jeans and leather jackets. And because you look like a fool, you can't sit here any longer. The bystanders allow that. To the organization, so it's estimated at a place like Mass General, and I'm sure the figure is very comparable, if not the same here at York or any other hospital across the country, that to onboard a new nurse, whether he or she is new to practice or whether she or he is new to the organization, their investment, and before you begin to see a return on investment, is about $60,000 in about 24 months. And what happens in organizations where bullying is allowed to exist is people come and go quickly. And so you never get your return on investment. You never get to develop an entire cohort, an entire service line of clinical excellence, because people are always coming and going. And as people come and go, people have to precept, and then you get tired because everybody you precept goes, so you don't want to do that. And then your reputation suffers. You don't want to work there. Got a bunch of witches over there. You don't want to go to that unit. Come over here. So reputation suffers. Money suffers. Ultimately, patient care suffers. Because if you don't have sufficient staff, you all have to take care of more patients. And as patients get sicker and stay longer and you get more frustrated, it becomes this vicious cycle. And patient safety is always at risk because in bullying, in disruptive behavior, we're afraid to ask questions. Communication, or the failure in communication, is what causes patient care to suffer. As I said to you earlier, I sat as the deputy director of the Board of Nursing for a number of years. But prior to doing that, I was the practice coordinator. And one of my functions as the practice coordinator was to read every complaint against a nurse that came in and to make an initial evaluation. Is this really a complaint, or is this just a bunch of garbage? And those things that really were complaint-worthy, if they weren't diversion or if they weren't substance abuse, which is a whole different issue, they were really violations of good ethical practice. At the center of it all, when you did root cause analysis, was this failure in communication. When this nurse, brand new nurse, sat across from me and I said to her, "Why did you give Pavlon IV push to your patient who wasn't intubated?" And she said, "Because the day before, my preceptor kept giving it to him because he was so agitated." I said, "Yeah, but the day before he was intubated. He was being ventilated. She was also giving him morphine, so the guy wouldn't go crazy being paralyzed. Why didn't you ask your preceptor?" She said, "Because I was afraid to." So a patient died and knew he was dying because the nurse was afraid to ask her preceptor. Wrong limbs have been removed because nurses were afraid to speak up. We have universal protocol because of these kinds of things. We have these professional issue kinds of committees because patient safety is paramount. None of us come to work to harm patients. I mean, we all come here to do something good. So why does bullying exist? So I started my journey in trying to understand this by thinking in a very old-fashioned way. And the way that I thought about it is, bullies produce bullies. If I'm bullied, then I'm going to be a bully. And this whole idea of the oppressed becoming oppressors. And although that does exist in several fields, education being one of them, where those who are oppressed learn that as the expected behavior and then become oppressors, and I made that leap thinking, gee, that must have what happened to me when I was a faculty person, and thought that that morning conference, when I asked you those millions of questions in preclinical conference about just trying to think I was helping you learn, but really what I was doing is I was eroding your confidence. That's what must have happened. Then we looked at this whole idea of role conflict and how as nurses we are taught to work as members of teams. We're always teams. And yet, one of our most significant colleagues, the physicians, are taught to act as independent practitioners. Captain of the ship, leader of the team. And that presents role conflict. This whole idea of repeated pattern, there's some suggestion of that, particularly when you look at people who've been sexually abused and what happens to them. But this is really where my study shocked me. I was expecting to find that those, because I studied nursing students, those nursing students who fit the criteria for being a victim, they would identify their clinical faculty as the bully. But I thought more importantly, they're going to identify that nurse. So we all know her, because it's usually a her. We all know her. When I taught nursing school, I would do anything in the world not to assign my students to her patients. We all know her. She sighs, she rolls her eyes, she looks at the assignment sheets and declares, well, this is going to be one hell of a shift. Oh, you're here again? We all know her. We all know how she loves a crisis, and when there isn't a crisis, she makes one. We all know when there's a sick call, she's the first one to volunteer, and then she's a martyr. We all work with her. And so I thought certainly students would pick her because what's really odd about her is students love her. Because her behavior is also undermining and subversive to faculty by saying things to students like, this is how we do it in the real world. Come over here, I'll show you how to do it. And they're very seductive, again, to create this court around them. Use this intimidation. Well, I thought for sure students were going to say, oh yeah, I recognized her. Overwhelmingly, and I did a national sample through the National Association of Student Nurses, overwhelmingly, the bully was identified as a peer, as the person sitting next to me in class, the person who was next to me in clinical. And that's what led me to the discovery of relational aggression. And relational aggression, it's really a mechanism in how we deal with or engage in conflict. And conflict is inevitable. And so it is a set of behaviors that are designed to cause exclusiveness and exclusiveness. So I decide, based on whatever criteria I have established as worth, whether you're worthy or not. And if you are, then you are allowed in. And worth has varying degrees to it. So you may be a very worthy person because you're a real good lookout. Or you may be really worthy because you bring some value that I need. But man, don't cross me, because all this stuff will now be directed at you. And the work that's been done on this looks at little girls. And they put 3 or 4 little girls in a situation, and they cause a conflict, usually like with a doll or something. And they watch what happens. And within a very short period of time, whoever they've caused the conflict with, the other backs have turned to her. And she's ignored. There's no violence, no screaming, there's no yelling. There might be a little name calling and a little pushing and shoving. But it's all this. And that's incredibly, incredibly hurtful. Versus if you do that with little boys, they will kick each other, they will punch each other, they'll pull each other's hair, they'll roll around on the floor, then they'll get up and they'll share a cookie. No, seriously. Because boys are allowed to resolve conflict in much more aggressive ways. We think it's okay. We call it little boy behavior, schoolboy behavior. We allow boys to engage in this kind of behavior. It's okay that they crash into each other on a football field. It's okay that they drag race down the street. It's okay that they do all of this macho stuff. It's acceptable. It's how men are supposed to act. But women aren't supposed to act that way. Women are still supposed to sit up nicely, be polite, be quiet, all of these kinds of things. Now, again, that's an overgeneralization, but the point is still true, that women will resolve conflict in these covert ways versus men who use very overt ways. And these become behaviors that, oh, by the way, all those like mean 8th grade girls, they grow up to be 18-year-olds, and then they go off to nursing school, and then they graduate nursing school, and they come to work in places like York Hospital. So they don't stop, like you don't get your high school diploma and say, that's it, I exonerate you, you'll never be a bully again. Mean girls grow up to be mean ladies. It's part of the behavior. And some suggest those behaviors can never be broken. Some believe that once that pattern is set as your way of resolving conflict, there's no changing you. If that's the case, then it's up to the rest of us to set an arena in which she is controlled and it is not allowed behavior. So we talked about incivility, we talked about bullying. In there is lateral violence, horizontal violence. Many people will use these terms interchangeably. Bullying, lateral violence, horizontal violence. There are some authors who say they're the same thing. There's an equal set of authors who say they are different. I swim in that camp. Lateral violence or horizontal violence is much more episodic, and it isn't necessarily targeted towards you because of you, the way that bullies are. Bullies target you because you are a target. And every one of us is a target at some point. You are a target if you're a student. You are a target if you're a new graduate. You are a target if you're new to the organization. You are a target if you get something that someone else thinks you shouldn't get. All of us are targets at some point in our life. Where this lateral violence kind of thing is, someone's just had a really bad day and they've been like really bad. But at the opposite end of the continuum is murder. And murder is the ultimate disruptive behavior. There's no coming back from this. And I've lived through murders within the workplace in my career. And I can tell you, it happens. People get murdered. They get murdered by each other. And the whole idea of this workplace violence thing, some of you remember way back, and then we had this saying, and we've used it in some very macabre sort of dark ways. Oh, you keep that up, I'm going to go postal on you. That's incivility, by the way. When you say something like that, meaning to be humorous, that's incivility. Because there was nothing good about this. Unfortunately, again, women are at the highest risk of being murdered in the workplace. And that's because, of 3.1 million nurses, only 6% of us are men. So, how do we prevent it? Well, we're doing it. We're doing it. And I have to publicly thank your leadership for inviting me and asking me to talk about this with you. I think it's very bold, it's very courageous, it's very positive that they want this role modeled as it will not happen here. And so we need to introduce tools, but more importantly, we need policy and procedure. So policy's okay. Policy by itself is not a big deal. You can have the policy on anything you want. You've got policy hanging on that corridor wall. You got policy on your badge. What's it? Kindness and loving? What's it? Loving kindness. Well, that's a policy. What's your procedures? Do you know what to do if you're bullied? Do you know what to do if you're a bystander? It's all in the procedure. It's all understanding what the organization wants. So we need to identify bullies before they strike, and they identify themselves. They're high conflict people. They whip things up. I remember those Sunday mornings as a nurse getting off the elevator 6:45 on a Sunday morning. First of all, there would only be 4 of us for those 41 patients because it was Sunday. And we had a sick call. And we'd be like, looking at the schedule, seeing who's on, we'd be like, not a problem, we'll handle this. Versus other times you get off the elevator and there's like 15 of you on, and you think, oh, she's in charge? Well, there goes the day. We know who they are. We need to try to understand why, though. Because behind all of this is some kind of need for power. Bullies perceive themselves as being in a position of power. And having it, holding it, using it is how they control the situation. But I'm always curious, what's the situation they're trying to control? And why do they need to feel like they're in power? It's all about the compliance. Do you have a policy and do you follow it? I was once on a panel and someone in the audience said, why does bullying exist? And you know what the answer is? Because it's allowed to. It's as simple as that. Bullying exists in nursing because we allow it. If we stop and we say enough, then it won't exist. And so I think you guys are on the right track with this whole idea of educating each other and how do you use education. So at the organizational level, some things that I've consulted on and things you find in the literature. Some of this was presented by other organizations at last year's Magnet Conference, which I thought was a brilliant strategy, that you create no bullying zones. So groups of nurses or units or areas undergo this kind of intensive training, and then they all get buttons or pins, and they are recognized within the organization as somebody who will not allow a bully. And this whole idea of creating community in which you contain this behavior and eliminate it if possible, or manage it, can be created by no bullying zones. What's your professional practice environment? And what does that mean? And the professional practice environment is based on your philosophy of nursing, your philosophy of nurses out of York Hospital. What do you believe? What are your values? What do you see your role as? What do you see your relationship to the patient as? The idea of a relationship-based care and understanding there are 3 relationships to that. One of the most important besides the patient is the relationship with team. So as a team, how do we work together? It's also a moral obligation. What always fascinates me is every single nurse in the world, if you ask them why they want to be a nurse or why they stay in nursing or anything to do with that, you know what they always say? What do you think they say? Why are you in nursing? What? You want to help people. You care about people. So we're a helping, caring profession, or we wouldn't be here. And yet, do we care and help each other? And what kind of a moral dichotomy is that? That we can be so kind to strangers, and yet we can't be kind to each other. I just find that fascinating. So if we start thinking about this in terms of relationship-based care and that relationship of team, you get this moral obligation. So for the nurse leaders in the room, this is first for a reason. If you don't address it, you support it. Simple as that. And I'm not afraid to stand here and say that to you. If you see this and you don't do something, then the failure of your action says you support a bullying environment, period. And I don't care if you no longer like me. It's the truth. Leadership starts at the top. Do you have a code of conduct? Do all of you know what is expected of me? It can be very simple. I'll be nice to each other, I'll buy Girl Scout cookies, whatever it is. What is expected of me? And if I don't live up to that, what is the consequence? What's the expectation? If I say, yes, I'm going to live up to this code, and then I don't, is there a consequence? Without a consequence, it doesn't mean anything. Do you have executive rounds? Do you hold town halls? Are you talking about stuff? Are you getting to issues of incivility? Are you getting to frustration? Are you getting to the idea that some people like change, some people don't like change? Some people want to stay where they are because I know it and I don't want to have to learn anything. I'm too old to learn another thing. I actually thought that myself. I have said to my own team, I think it's time for me to leave. Because I only have a little bit of space left in my head, and I don't think I want to learn an electronic medical record, an integrated electronic medical record. I just don't think I want to do that. And some of my team are in their 70s. They've been on staff for 50-something years. In fact, I was a student under one of my staff. And she embraces change more than anybody I've ever met in my life. And I think, what an inspiration. What a role model. What kind of education? Is this part of your onboarding process? Is this part of your preceptor development? What are your physician staffs learning? What are other departments learning? This isn't just our problem. It exists everywhere, particularly if the bullies are in nursing. Communicate, 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 and just when you think you've communicated enough, communicate again. Have zero tolerance and always confront the behavior. But before you confront the behavior, this is really important, ensure your own safety. Because you don't want that bully to move down the other end of that continuum. You don't want them to become violent or explosive. Always ensure your safety. For you as nurses, for all of us as nurses, if there are policies in place, learn them. Use them. That's why they're there. They're there to minimize chaos. They're there to empower you. Do you have code words? Like that group that I told you about at Magna, they had those little buttons. In ORs, they'll have code words. Like when a disruptor comes in. And what happens is when I hear that code, it's a call to arms. And we all go to the potential victim. And we cause a physical presence that's too anxiety-provoking for the bully. And they back down. Cognitive rehearsal is a tool that I use a lot, and I teach a whole class on this. And very short, cognitive rehearsal is one of those things where somebody says something to you, and you're left absolutely speechless. Only to have 3 hours later, I wish I had said. Well, the I wish I had said is cognitive rehearsal. So as a brand new nursing regulator, I was sent off to my first Department of Public Health meeting. And Carol has heard the story a couple of times. And it was right after a very paradigm-shifting event in healthcare called the Betsy Lehman situation. And of course, the Board of Nursing was not welcomed anywhere. We were seen as the big bad wolf. We were seen as, coming out of our ivory tower. We were just seen as like the bad people, and of course, like we were the villains. And I had to go to this public health meeting, and I don't know, 25, 30 people around it. And the woman from Department of Public Health, who actually had been leaking confidential information to the press, that resulted in a negative perception of the Board of Nursing because politically we wouldn't do what she said, ran the meeting. And I thought, oh, I'm screwed now. And so we went around the room and we had to introduce ourselves and where we were from. And she knew who I was and she knew where I was from. But she made me publicly state it. And I said, I'm Gino Chisari. I'm from the Board of Nursing. I'm the nurse practice coordinator. And she bellowed. I have no idea what that means. And I said, well, it's the job that so-and-so had. She said, oh, well, you've got awfully big shoes to fill. And, I turned scarlet red and I did all these kinds of things. And then, as I was walking back to my office after the meeting, I thought, so the next time somebody said that to me, I came back with, well, luckily for me, I have big feet. And that's cognitive rehearsal. Cognitive rehearsal is being prepared for what you know is going to happen. You don't know when, but you know how, and you know by whom. Because bullying, we said, was what? Targeted, intentional behavior meant to publicly humiliate you. So if you know what's coming, you can be prepared for it. If you have bullying, you have incivility, report it. I know nurses don't like to report, no, I feel bad. Oh, it's okay. Oh, all this, oh. Oh yeah, I'm not reporting it because no, I'm afraid. Oh no, I'll get fired, I'll get called, whatever it is. My attendance hasn't been good, this is what they need to get rid of me. Oh yeah, don't say anything, you'll be gone. Oh no, you say anything, that's it. You're working Christmas, Thanksgiving, and Easter. Don't do it. Seriously, don't we all, when we say this crazy stuff to each other? Address it. Bullying will stop if you stop it. Period. By not addressing it, you are allowing it to continue. It's as simple as that. If you are the victim, keep a journal. Journal will do a few things. First of all, it's very cathartic. But second of all, it's evidence. Keep it. Please don't be a bystander. If any of you see it, do something. Say something. Why would you let one of your colleagues be hurt? Even if you don't like your colleague. Because this isn't about liking everybody. You're not going to like everybody. I work with plenty of people I don't like. There are plenty of people that Carolyn Labrini and I work with. I would never have them to my house. I wouldn't go to their house. But if they were bleeding, I'd get them a Band-Aid. So why don't we take care of each other? And let's reflect on our own behaviors. Let's be sure that we're not a bully and someone is protecting us. So at the end of all of this, enough is enough. Let's stop eating our young. Let's eliminate bullying. So you're gonna take this journey, enough is enough? Yes? All right, let me hear you say it.
Yes. Yes.
Not yes. Enough is enough. Say it again. I didn't hear it.
Enough is enough.
I still didn't hear it.
Enough is enough.
One more time with spirit. There you go. Thank you so much.